Hello and welcome back to the Irish Hematology Oncology podcast after taking a week's break. I'm Owen Tab, I'm your host and pharmacist working in University Hospital Waterford. So far in our ongoing exploration of the world of chemo, we often focus on the main event, the powerful chemotherapy drugs themselves. But just like a successful sports team relies on a dedicated support staff, chemotherapy regimens depend on a range of ancillary medications to ensure optimal patient outcomes. These unsung heroes of cancer treatment may not grab the headlines, but they play a crucial role in managing side effects, preventing complications, and even enhancing the effectiveness of the chemotherapy drugs themselves. In previous episodes, we've touched on the importance of pre-medications in preventing infusion-related reactions, and I'm excited to share that we have a comprehensive episode on antiemetic care in the works as well, so stay tuned for that. But today we're shining the spotlight on a different set of ancillary medications, those that are specifically paired with certain chemotherapy drugs to address their unique side effects and risks. We'll be diving into the nitty-gritty of why these medications are needed, how they work, and how to administer them safely and effectively. The premise of this episode was initially to look at cystatin hydration, but then when I was thinking about it, that wasn't enough to talk about in one episode. So then I went on, and I kept adding drugs. So I suppose that this episode is more so about those drug-specific considerations, the bits and bobs of chemotherapy. So as a result, there might be a few things that I've missed out on, but these are the kind of random drugs that I'm associating with ancillary medications and specific considerations for those. So let's start off. First up, we have Pemetrexed with vitamin B12 and folic acid. Pemetrexed is a chemotherapy drug frequently employed in the treatment of lung cancer and mesothelioma. Now, Pemetrexed, while effective, has a bit of a downside. They can act like a bit of a nutrient thief, depleting the body's stores of vitamin B12 and folic acid. Think of these vitamins as the essential building blocks for your body's cells. Without enough of them, the cells can't function properly, leading to a range of unpleasant symptoms like fatigue, weakness, and even nerve damage. So to counteract this depletion, we supplement patients with vitamin B12 and folic acid. This isn't just about preventing deficiencies, it's also about protecting patients from the potential toxicities of Pemetrexed. Studies have shown that supplementing with these vitamins can significantly reduce the risk of severe side effects like neutropenia, which is, as we learned from previous episodes, a light white blood cell count, and thrombocytopenia, a low platelet count, which can leave patients vulnerable to infections and bleeding. The typical regimen involves taking oral folic acid, normally 0.4 milligrams, starting several days before the Pemetrexed infusion and continuing for about 3 weeks after. Vitamin B12 is usually given as an injection, either intramuscularly or subcutaneously, about a week before the Pemetrexed infusion and then monthly thereafter, or 12 weekly thereafter, depending on the regimen. Additionally, it's crucial to monitor patients closely for any signs of vitamin B12 or folic acid deficiency, even with supplementation. This might involve regular blood tests to check vitamin levels and a close watch for any symptoms like fatigue, weakness, or tingling in the hands and feet. By proactively addressing the potential for vitamin depletion, we can ensure that our patients receiving Pemetrexed are not only protected from harm, but also supported to achieve the best possible outcomes from their treatment. So, now let's talk about Docetaxel. This is a chemotherapy drug frequently used in various cancers, including breast, lung, and prostate. One of the common side effects of Docetaxel is fluid retention, which can lead to uncomfortable swelling in the hands, feet, or other parts of the body. Imagine it like a slow leak in a pipe. If left unchecked, the water will gradually build up and cause problems. To prevent or manage this fluid retention, we often prescribe corticosteroids like dexamethasone alongside Docetaxel. These steroids work by reducing inflammation and promoting the excretion of excess fluids. Think of them as, I suppose, a plumber coming in to fix the leak and drain away that accumulated water from that slow leaking pipe. The standard dexamethasone pre-medication regimen for docetaxel is 8 mg taken orally twice a day for 3 days, starting the day before each docetaxel administration. It's important that these patients receive at least 3 doses of dexamethasone before the docetaxel infusion to ensure adequate protection against fluid retention. In some cases, if a patient misses their oral dexamethasone dose, the prescribing consultant may decide to administer a single 20 mg dose of dexamethasone intravenously immediately before the chemotherapy. This can happen in cases whereby the prescription hasn't been sent out to the community pharmacy and the patient hasn't received that oral dexamethasone dose. While steroids can be very effective in managing fluid retention, it's important to use them judiciously. Long-term or high-dose steroids use can lead to a range of side effects, including increased appetite, mood swings, difficulty sleeping, and even bone thinning. Therefore, we always weigh the benefits of using steroids against potential risks and tailor the treatment plan to each individual patient. By proactively managing fluid retention with steroids, we can significantly improve the comfort and quality of life for our patients undergoing docetaxel treatment. It's a small intervention that can make a big difference in the overall experience of the patient's cancer journey. So now let's go on to Irinotecan and the use of atropine. Irinotecan is a chemotherapy drug primarily used in the treatment of colorectal cancer. And Irinotecan is a valuable tool in our arsenal, but it comes with a unique and potentially challenging side effect known as an acute cholinergic reaction. Imagine this reaction as a sudden summer storm. One moment you're enjoying a peaceful picnic, and the next you're caught in a downpour of unpleasant symptoms. These can include diarrhea, abdominal cramps, excessive sweating, and even a slower. It's not a pleasant experience for our patients, and it can even be life-threatening if not addressed properly. The culprit behind this cholinergic reaction is a neurotransmitter called acetylcholine. Irinotecan can cause a rapid surge in acetylcholine levels, leading to the cascade of symptoms I've just discussed. To counteract this, we have a trusty antidote on standby called atropine. Atropine works by blocking the action of acetylcholine, effectively putting a stop to the storm. It's like a chemical umbrella, shielding the body from the downpour of acetylcholine and its associated symptoms. To prevent those acute cholinergic reactions, a dose of 0.25 mg of atropine can be given intravenously before the irinotecan infusion. If symptoms of a cholinergic reaction occur despite this pre-medication, the atropine dose can be repeated every 10 to 15 minutes until the symptoms subside, with a maximum dose of 2 mg in a 24-hour period. Prompt administration of atropine can make all the difference in managing this side effect and ensuring the patient's safety and comfort. While atropine is generally safe and well tolerated, it in itself can cause some side effects such as dry mouth, blurred vision, and constipation. These are usually mild and temporary, but it's important to be aware of them and to monitor patients accordingly. And lastly, let's turn our attention to 5-fluorouracil, often abbreviated as 5-FU. This chemotherapy agent is a cornerstone in the treatment of various cancers, particularly colorectal cancer. While it boasts an impressive track record in fighting cancer cells, 5-FU can affect healthy cells, leading to a range of side effects. Think of it as a powerful cleaning agent, highly effective at removing stubborn stains, but also capable of damaging the surrounding surfaces if not used carefully. One of the key ways we mitigate 5-FU's potential harm to healthy cells is by using folinic acid. It can also be known as leucovorin. But it's not just about protection. Folinic acid actually plays a dual role. So first of all, it has a protective role. It acts as a rescue agent, helping to minimize the damage to healthy cells. Folinic acid acts as a form of folic acid, a vitamin that we've mentioned earlier on that is essential for cell growth and repair. By providing extra folinic acid, we essentially give healthy cells a boost, helping them to withstand the toxic effects of 5-FU. It's like providing a protective shield to those delicate surfaces we mentioned earlier. Second, and perhaps surprisingly, folinic acid actually enhances 5-FU's ability to target and kill cancer cells. It does this by helping 5-FU bind more tightly to an enzyme called thymidylate synthase, which is crucial for DNA synthesis. By inhibiting this enzyme, 5-FU disrupts the cancer cell's ability to replicate and grow, ultimately leading to their demise. The specific dosage and schedule of folinic acid can vary depending on the 5-FU regimen being used. In some cases, folinic acid is given as a bolus injection before the 5-FU infusion. In other cases, it's given as a continuous infusion alongside 5-FU. The dose of folinic acid is typically much higher than the standard daily requirement for folic acid, as we need to ensure there's enough to protect healthy cells and enhance the action of 5-FU. For example, in the regimen FOLFOX, the folinic acid dose matches the dose of the bolus 5-FU dose. It's important to note that while folinic acid is generally safe and well tolerated, it's not without its own potential side effects. These can include allergic reactions, nausea, vomiting, and diarrhea. As with all medications, we carefully monitor our patients for any adverse effects and adjust the treatment plan as needed. By understanding the dual role of folinic acid in 5-FU treatment, we can better appreciate its importance for maximizing the effectiveness of chemotherapy while minimizing its potential harm to healthy cells. It's a true example, I suppose, of how ancillary medications can work hand in hand with chemotherapy to achieve the best possible outcomes for our patients. And you know what, guys? I think I'm going to leave it at those guys for today. Next week, we're going to hit the cisplatin hydration and folinic acid rescue and methotrexate regimens. What else do I have here? Mesna in cyclophosphamide and ifosfamide regimens. And we will tackle those. I'm just conscious of time and I don't want to be going on for too long. That needs to be another podcast in itself. So we'll do that next week. So, as always, I'd like to thank you guys for listening in. I'm sorry I took a week off there last week. It took a bit longer to write this podcast than normally has been before. Again, just to say that I encourage you all to share your thoughts and feedbacks on this episode and any of the previous episodes by filling out the feedback form in the show notes below. Your input has always been invaluable in helping me build the show and picking out topics and tailoring it to your interests and needs. I recommend that you use our CPD document for the pharmacists out there to fill in your IIOP CPD requirements. Anyway, thanks a million, guys, for everything, and I'm going to end on this important disclaimer as always. This podcast is for educational purposes only. Remember, the field of cancer care is always advancing and new research may lead to changes in treatment approaches or protocols. Always consult with your own team for personalized guidance and discuss any information from this podcast with them. Seek information from trusted local and national resources for the most up-to-date recommendations. Thanks a million, guys, for joining me as always, and until next week, see ya.